So please join me in welcoming Dr. Patricia Gordon.
Well, this is really an honor to be here. I can't begin to tell you how humbled I am and how grateful I am to be able to share Cure Cervical Cancer with you and some of the knowledge that I've learned over the last 13 years. So thank you for having me. As a doctor, I am passionate about the health of our global community and the importance of collaboration in addressing the world's most pressing health issues. Well, as I was already introduced, but what you don't know is that I'm a UCLA Medical School graduate and a graduate of this UCLA Radiation Oncology program, but you can't ask me how long ago. I worked as a radiation oncologist before leaving my practice to address the global epidemic of cervical cancer. I founded Cure Cervical Cancer, a nonprofit devoted to the early detection and prevention of cervical cancer in developing countries. I'm excited to speak with you today to discuss the global impacts of the COVID pandemic and how cervical cancer exemplifies, the impact of the pandemic on health inequity worldwide. I'm also here with our program coordinator, McKenna. She has traveled to many of our clinics all over the world, and she's been with us for the last 2.5 years. And if anybody knows how to replace McKenna, please let me know, because we are looking for a program coordinator. And by the way, all of our program coordinators in the last 13 years, I've had 13 of them, have gone on to medical school. So I have a good track record. Since I established Cure Cervical Cancer in 2012, we have been dedicated to the early detection and prevention of cervical cancer around the globe. Now, 10 years later, Cure Cervical Cancer has grown. We have 106 sustainable clinics in 10 countries, and we have the first ever mobile testing and HPV testing and treatment clinic. We've screened nearly 180,000 women, treated over 11,000 women. We've trained 720 professional healthcare workers and 1,300 community healthcare workers in cancer care prevention. But today we are going to discuss the impacts of the COVID pandemic on global health systems and look at how the epidemic of cervical cancer is a specific example of how the pandemic exacerbated existing health inequities in low-resource settings globally. And we will discuss how our organization pivoted our programs in the middle of the pandemic to create more COVID-conscious, more effective cervical cancer screening and treatment programs for women in low-resource regions. The health impacts of COVID go far beyond the virus itself. The pandemic has increased deaths from other causes due to disruptions in health services and routine immunizations. Fewer people sought health care, and there were shortages of funding for non-COVID services. WHO surveyed 135 countries early on in March of 2021 and highlighted there were persistent disruptions at a considerable scale. And just 1 year into the pandemic, 90% of all countries reported one or more disruptions in essential health services. These disruptions to essential health services have devastating consequences. Modeling predictions estimate nearly 15 million excess deaths over the course of the pandemic. This figure captures not only the confirmed deaths from COVID-19, but it also the deaths attributable to the overall crisis conditions caused by the pandemic. The effects of the crisis conditions caused by the pandemic and the existing inequities are exemplified in Kenya. COVID hit Kenya hard. The healthcare system, which already lacked critical resources in pre-pandemic times, struggled to respond. Healthcare workers went on strike for 70 days to protest a lack of access to PPE, disrupting essential healthcare services even more. Outpatient visits, screening and diagnostic services, routine immunizations were all adversely affected. For already vulnerable populations in low-income countries, these disruptions magnify existing inequities. One of the essential health services COVID significantly disrupted was cancer care. During the pandemic, healthcare systems worldwide struggled to maintain routine services, leading to the reduction of utilization of cancer services. The pandemic caused disruptions to funding and access to cancer screening programs, as well as delays and logistical challenges in accessing treatment services. These effects are exacerbated in low and middle income countries where medical resources are limited and cancer screening rates are already low. So the impact of the pandemic on cervical cancer, my organization's focus area, is especially illustrative of how the pandemic worsened existing health inequities in low resource settings and the importance of creating solutions that close the gaps in access to care around the globe. Every 2 minutes, another woman dies from cervical cancer. Cervical cancer is one of the leading causes of cancer deaths for women in resource-poor countries, with over 340,000 women per year dying a painful, undignified, often bloody death. And the kicker is, cervical cancer is nearly 100% preventable with early detection and treatment. Cervical cancer screening and treatment services were already difficult to access in many communities around the globe, and during the pandemic, prevention efforts faced huge setbacks. At the start of the pandemic, our clinics exclusively used the very simple method called see and treat, visual inspection with acetic acid. Visual inspection with acetic acid is vinegar. We used the vinegar test, which at that time, WHO said was the gold standard for screening for cervical cancer in poor and resource-poor countries. All you need is vinegar and a cryotherapy gun or a thermal ablation device. With the vinegar test, precancerous lesions react with the vinegar and turn white, allowing a healthcare provider to see the lesion with their naked eye and treat them with cryotherapy or thermal ablation. And so for nearly a decade, this is what the method see and treat, our see and treat clinics used to prevent cervical cancer worldwide. Here you can see what a healthy cervix looks like after the application of vinegar. There's no white lesions at all. The little white, go back for a sec. The little white that you see is a flash from the camera. Next slide. And here's what a cervical precancer looks like after you spray on some vinegar. Those dense white lesions are precancer, which can easily be ablated to prevent the development of an invasive cancer. And it takes only 20 seconds. But during COVID, when already limited medical resources had to be directed towards the pandemic, and many people feared that they would catch COVID at a healthcare facility, the volume of women that were coming to our international see and treat clinics dramatically decreased. And during that same period, WHO called on the global community to eliminate cervical cancer by 2030 through an accelerated action of vaccination, screening, and treatment. The goal is 90% of girls get vaccinated against HPV by the age of 15. 70% of women get screened by the age of 35, and again by the age of 45. And that women with pre-cancer, and that 90% of women with invasive cancer get managed, and 90% of women with pre-cancer get treated. And this is the reason why we can eliminate cervical cancer, because it's a disease of inequity. 90% of cases and deaths occur in low to middle income countries where women simply don't have access to vaccination, screening, or treatment, which is very clear on this map showing the global incidence of cervical cancer. And on this map showing the global mortality for cervical cancer. And this is precisely why we at Cure Cervical Cancer work in the countries we work in. We bring life-saving treatment to communities where women are dying due to lack of access to these services. Over the years, best practices for cervical cancer prevention have changed, and technology has improved. In 2021, WHO updated their guidelines for screening and treatment of cervical precancer. The new WHO guidelines recommended HPV DNA testing as the primary screening test for cervical cancer. HPV DNA testing. Well, how was I going to get an HPV testing machine to Kenya? Well, that's what the rest of this is about. HPV testing is the gold standard. Persistent infections with high-risk HPV cause nearly 99% of cervical cancer. So let's get that clear. HPV causes cervical cancer. I think most of you know that, but for those of you who don't, that's what this rest of this talk will be about. So HPV testing identifies women who are at the highest risk for developing cervical cancer. Unlike the vinegar test, which requires that every woman receive a pelvic exam, HPV testing can be carried out by each woman getting a self-sample of vaginal fluid. HPV testing has a greater sensitivity and specificity than the vinegar test and pap smears. And HPV testing has a longer screening intervals than the vinegar test and pap smears. Once you had an HPV test, you don't really have to have another one for 5 years. All of these factors make HPV testing the best tool we have for screening for cervical cancer. But HPV testing is more difficult to bring to low-resource countries, especially in rural communities. The pandemic made it even more difficult to begin to implement the new WHO guidelines. With funding and medical resources focused on COVID and women hesitant to visit health facilities, existing cervical cancer screening programs in Kenya saw a nearly 50% decline in use. Innovations to scale screening were needed more than ever before. And that led to the creation of our Mobile Health for Mamas project and HPV testing and treatment mobile clinic. As we saw earlier, cervical cancer is a disease of inequity. Without equitable access to preventative care, women will continue to die needlessly from this preventable disease. COVID disruption to cervical cancer prevention efforts made creating accessible HPV testing and treatment programs more important than ever. Without them, the elimination goal of eliminating cervical cancer in 2030 would further slip away. Cure Cervical Cancer is taking the lead to demonstrate an HPV testing model in a low-resource context. We are demonstrating that we not only can bring this gold standard test to low-resource areas in an innovative, cost-effective way, but that models like ours can be used to dramatically increase cervical cancer screening coverage in hard-to-reach areas due to potential scale. And this is the model, and our model is COVID conscious, because self-sampling testing means that only HPV patients will require vaginal exams. HPV testing significantly reduces the healthcare provider-patient contact compared to the vinegar test, see and treat, where every patient had to be examined. The mobile clinic also operates fully outdoors, allowing for greater social distancing. Well, here's an aerial view of our mobile clinic outreach in rural Kenya. We do 3 mobile outreaches a week in different areas of northeastern Kenya. Here you can see our registration tent, patient education tents, vaginal fluid self-sample collection pods, and in the way back, our bus that contains our mobile laboratory. Our treatment tents over there are where HPV positive women can get their thermal ablation treatment right then and there on the same day. Everything you see here was taken through customs in Nairobi, except the bus. And here's an aerial view of an outreach setup in a more urban environment in Kisumu, Kenya. That's the beauty of this model. We can really set it up anywhere. And as our program has grown, we've invested in specialized mobile vehicles. A Hino truck has been converted to function as a lab on wheels, and a Land Cruiser to transport our team of trained providers. Our plan is that these can be replicated and deployed in other resource-poor communities around the globe. So now I want to talk about how this innovative model works. There are 3 components that allow us to stop cervical cancer before it starts: testing, treating, and linking. First, testing. We use HPV testing to identify women with high-risk HPV who are at risk of developing cervical cancer. Our mobile laboratory brings self-sample HPV testing to women who have limited access to screening. On the top left-hand side here, you can see the pop-up tents where women can privately collect their self-sample vaginal fluid, and on the bottom, our lab technician, Adriano, inside our converted minibus processing samples. And this is the technology that makes our mobile laboratory possible. It is a fully portable PCR HPV testing machine, the same machine used for COVID testing. There have even been proposals that using old PCR testing machines, and we know there are tens of thousands of PCR testing machines. We can repurpose these machines to HPV testing machines in the future, and I really hope we see that happen. Our testing machine can run up to 94 samples at a time and provide results within an hour. We usually run a group of women in the morning and then another group of women in the afternoon in our outreaches. And again, we're doing this 3 times a week at different locations each time. Here you can see the machine on the left in our mobile lab. It runs on solar power, so it can function anywhere. The next component is treat. We offer thermal ablation treatment to all eligible HPV-positive patients based on the WHO treatment algorithm. We designed mobile clinic treatment stations that can be set up anywhere, which you can see in this photo on the bottom left. On the top is one of our Cure Cervical Cancer trained nurses, Mercy, performing the quick, painless thermal ablation treatment for an HPV positive woman at an outreach in rural Kenya. It takes 20 seconds. And the last component is LAGHC. This is how we make sure that women who need higher levels of care than we can provide at our outreaches get that care. We have a dedicated social worker, Millicent, who you can see here on the left, who makes sure that women who need it are linked to advanced services. She helps women make appointments, enroll in the Kenyan health insurance plan. She gets them financial and psychosocial support. She walks with them every step of the way to navigate the healthcare system. Something else that's absolutely crucial to the success of every component of our program is education and empowerment. For women to be willing to access our services, we need to prioritize health education and combat stigma for not only the women that we serve, but for the community leaders and men in the community. We make outreaches a venue for men and women to ask whatever health questions they may have. In the areas where we work, there are also very high HIV positivity rates. HIV positive women are 6 times more likely to develop cervical cancer, 6 times more likely. And they develop it faster and younger than HIV negative women. So because of this, we target our outreaches to areas where there is an especially high HIV positivity rate. In Kisumu County, where our project is based, and Kisumu is about an hour airplane ride north of Nairobi, the HIV prevalence is about 18%. In the fishing towns on the shores of Lake Victoria, which is very close to Kisumu, where there are many women that rely on sex work to survive. High rates of HIV prevalence go hand in hand with the elevated risk of cervical cancer. So to give you a better idea of what all of the components look like put together, here's a very short video of one of our HPV testing and treatment mobile clinic outreaches in Rongo, Kenya, and I'll try to take you through that. Here we have a mock patient who's actually one of our nurses coming into the mobile outreach. And the first thing she does is she goes to registration area and she's talked through, we get all of her data and we see if she's a member of the Kenyan insurance plan. If she isn't, we try to make it so that she does. Now she's walking to a tent where she's going to be educated on how to take a self-sample. And here is our nurse walking into one of our pop-up tents that McKenna has brought through customs in Nairobi, and she takes her vaginal fluid test. It's then taken in a batch of 90 or 93 inside the mobile laboratory, and Adriano here is making is running the lab test for the 93 patients in the morning. And now she goes to get some patient education, and actually it turns out that she was HPV positive, and she's been asked if she'd like to receive further education and possibly thermal coagulation. And here we have one of our nurses. She's agreed, the patient has agreed, and one of our nurses is now spraying vinegar on the cervix. And the reason we do that is we want to make sure that her lesion, we know she's HPV positive, is of a certain size that we can treat it with thermal coagulation. If it's too big, we have to link her to another facility that does LEAP or even something else. And now she's left our clinic and received the thermal coagulation, and she's Fine. She has to come back in 5 years. Pretty cool, huh? Yeah, the first mobile HPV clinic in the world. So here's our track record. Thank you. That just made me have some goosebumps. And that's what this is about, so thank you. So here's our track record. In a little over a year, and it's only been up for a year, our HPV testing and treatment mobile clinic has tested 11,224 women for HPV and treated 2,226 eligible HPV positive women to prevent the development of cervical cancer. And we have successfully linked 50 women to higher levels of care. And because sustainability is the key to successful intervention, we've worked hard to build capacity interventions. We've worked hard to build capacity within the local healthcare system. For HPV testing and treatment mobile clinics alone, we've trained 55 healthcare professionals, 1,000 community health workers in cervical cancer prevention. We've also trained 6 lab technologists in HPV testing, just in case Adriano needs some help. The COVID-19 pandemic exposed and worsened the existing health inequities in low and middle income countries. Now more than ever, we need innovative, sustainable, scalable solutions to close gaps in access to care around the globe. Ultimately, our dream is that our model can be scaled and replicated throughout Kenya and around the globe to expand access to cervical cancer screening and treatment and bring us one step closer in the goal to eliminate cervical cancer. Well, thank you very much for allowing me to talk. And I'm happy to answer questions, but probably McKenna will do a better job than me. And by the way, you know, we still have that job opening. So if any of you know anyone, it's a fantastic experience. Any questions? Okay.
For anyone interested in asking a question, if you could please come line up at the mic so you can ask them. There's one on that side as well. Thank you.
Hi. Thank you for this incredible talk and for the work you're doing. I guess my big question is what are the main barriers to expansion, and are any of them political or is it financial? Or
just a second. The real barrier to expansion is financial. This is not an inexpensive project. And if we had, we have many grants, and if we get the grant that we are hoping that we get, we will be able to have another whole mobile clinic. The other problems we can just get through. We can get through any of the other problems.
I guess just in terms of interfacing with the existing health systems, and if there's any kind of political or kind of like infrastructural issues with that.
Just to say that that's easy, it would be a lie. It's often very difficult. But it's something that we can do. My team has been doing it for 13 years with the See and Treat program, so we know what to expect. We know that we have to go to the local government first, and we have to get them on board. We know that we need the local stakeholders on board, and sometimes we have to pay ridiculous amounts of money for that privilege. That's just the price. Yeah. Yes, you absolutely.
And just to add to that a little bit, we also work really closely with the local ministries of health and healthcare systems to make sure that these models are also building capacity in the local systems. It's not just coming in and providing care and leaving with a vacuum. So we really work to train nurses and community health workers. And a lot of the women that we test in these outreaches are then linked with local healthcare facilities where the local healthcare workers have been trained by our staff. And we have a brigade of kind of master trainers within the local healthcare system to make sure that there's not a vacuum of care that's left behind after we leave.
Thank you.
I just want to say first, thank you so much for your time, and this was super eye-opening.
and great work that you've been doing. My question is that oftentimes in different cultures, there's a lot of stigma against reproductive health. How has Cure Cervical Cancer earned the trust of these communities? What kinds of steps were taken?
McKenna will be better at answering that because she wrote an essay on it.
Sure. So I think stigma is a huge barrier for any reproductive health project. I think the main way that we've combated that is to make sure that first and foremost in any community that we go into, that we're training the local community health workers. That way, the people who are providing health education are your peers and your neighbors. People really trust information that comes from people who they know, who are from their own culture, who really understand the barriers that they're facing to accessing care. So when we train these community health workers, it's really different in every single community what the different stigmas are, or different myths and misconceptions. But at the end of the day, the most effective thing is to sit down with leaders in the community, figure out what the myths and misconceptions or stigmas might be in each unique neighborhood, and then really deploy the community health workers or even peer educators who sometimes are not formal community health workers, but who are just women in the community who are interested in making sure that their peers access care services, and sending them out with the knowledge of what the misconceptions are and the correct information to dispel that, to mobilize women. Thank you.
Hi, my name is Matthew, and I'm the QI lead on a cervical cancer screening program at a community clinic in LA. And we've been trying to start an HPV-only self-sample collection program because we see a lot of women experiencing homelessness. It's not very common that they're able to come into the clinic for all the needed follow-up. And the answer that we've been getting while trying to start this up is that, if we do HPV only, we can't do co-testing. It's marginally less sensitive. But it's been, canonized as the WHO's standard. So what would you say in response to some of these, some of this pushback that we get trying to start a similar thing here?
Well, HPV testing is the gold standard. I'm not sure where your data is that something else is better. What are you?
Yeah, I guess it's the comparison between co-testing with PAP and HPV versus HPV
okay, co-testing. I'm sorry. Yeah, co-testing would be a great idea, but that's even more money.
Yeah, exactly.
So that it's doing a Pap smear where we are in the middle of nowhere is almost impossible, because then we have to take the slide back. We have to create a slide, and then we have to pathologist has to look at it, and then we have to go back. So it's just completely not something we can't do.
Yeah, exactly.
And HPV is the gold standard by WHO, so we kind of got lucky. We don't have to deal with Pap smears.
Well, thank you.
You're welcome.
Hello. My question is also related to stigma as well, but given that a lot of countries, there's a lot of taboo surrounding sexual and reproductive health, I saw one of the goals was to have more than at least 90-something% of girls younger than 15 to be fully vaccinated. I was just wondering about the outreach efforts. Are they primarily targeted more towards the parents of these young girls, or both the parent and the young girl, or more towards the parents since they're the ones taking them to the clinic often? I was just wondering who's the more target audience.
It differs from country to country. In certain countries, if you're in third grade, all third graders will hopefully get vaccinated. Now, having said that all third graders will get vaccinated, that's a lofty goal. Do you have anything to add to that? I'm sure you do.
Yeah, so I think that in a lot of places, educating parents is really the focus. Like you mentioned, parents are ultimately the ones making those final healthcare decisions for their children a lot of the time. I think a lot of the time we don't personally focus on vaccination with our efforts, but I think that it is really important when we train community health workers that at the same time that we're educating women about their own health and their own risk of cervical cancer, that we're really extolling to them that this is something that they in areas at least where the vaccine is available, could have the power to prevent for their children. And I think a lot of women, especially in the settings where we work, have been either personally affected by cervical cancer or know someone who has. So really explaining to the women that, you know, the great impact of cervical cancer that they're seeing in their own communities is something that can be prevented for their children through vaccination is really important. But I think you're right, it is a huge barrier that hasn't been fully overcome, which is the association of the vaccine and sexual activity, which is a difficult one to overcome. And like Dr. Gordon said, it's really community by community how to overcome that.
Thank you.
I also wanted to say thank you to the gentleman who just asked the last question for doing cervical cancer screening here in our vulnerable communities, because that's something that, you know, I really admire you for doing that. I would love to actually know more about what you're doing.
Yeah, I'll send you an email. I have plenty more questions I want to ask.
Great, or come to the office.
Definitely.
Okay.
Thank you so much, Doctor. That was a well-articulated report. And one of my questions has been asked on stigma and how the women deal with it, because I know because of the myths and misconception, it's a lot to really get them out to come for that and what happens and how the families take it, you know, but you did a good job on that. But I'm going, my second question is, how were you able to get the country of selection and the, you know, the sites in each of the country for the selection that you did? Because you have about 12 countries there and then you have sites and still. What was it for you? What strategies did you take to know that this is the place that had a high level of, you know, cervical cancer that you needed to work with?
Well, we showed a slide which showed the incidence of cervical cancer globally, and then we showed another slide where the incidence of deaths in those countries, and that's what determined initially where Cure Cervical Cancer went and where I decided that we should go in the beginning years. And then it just became overwhelming that other countries found out about it, and then we'd have to pick and choose areas that really had the highest incidence of cervical cancer. The reason we chose Kenya for the mobile HPV project was that we were truly embedded in the culture, in the government, in the stakeholders in Kisumu, Kenya, where we already had 3 dozen clinics there. I had been going there now for 9 consecutive years, maybe a couple of times a year. And we were well known, we were respected, so we could, you know, do this project, and we knew many nurses and other people that were willing to leave their jobs and come work for us exclusively. So that's how that got started.
Oh, thank you so much.
Hi, Dr. Gordon. Thanks so much for joining us today. My work is all in basically like community-based delivery of sexual and reproductive health services in South Africa. And one question that I had related to the test and treat model as part of Cure Cervical Cancer is, so, you know, you mentioned that, you know, you have a batch of samples that are run in the morning and some that are run in the afternoon. So do women wait at the clinic or at the site, and do you ever, you know, notice like women leaving because they have to be elsewhere, or, you know, just expanding more widely, what kind of barriers have y'all noticed during the implementation of these mobile sites that you'd like to kind of improve on moving forward?
Oh, what you just touched on breaks my heart. And it's those women who were there in the morning that got their test, and it turns out that they're HPV positive, but they had to go home to tend to the field. They had to go home because of childcare. Their husband wouldn't let them get the treatment.
Yeah, we see a lot of that in Cape Town as well with the STI testing and treating, and so
that breaks my heart. That's and I'm always trying to figure out ways to capture those women, to get those women back. And that's why we do such a big program of education. As soon as the women have the test, we educate them why this test is so important. That's what we're doing while they're waiting. We try to engage their husbands. We want their husbands to come to the testing so that they too learn about it. The more everybody knows and the more everybody's educated, the higher our rates of retention will be. McKenna will be able to answer this question with some more details, right?
Sure. So another thing that we've found really important is kind of just more geographically the outreach location. So we try to conduct these outreaches in areas where the women who are coming to the outreach, maybe even if they do need to go home in the waiting period, which is about an hour and a half, which when we say it sounds very short, but if you have a busy schedule and children and a career to tend to, maybe you can't wait. So sometimes we have success with having women just come back in an hour and a half after they've been initially tested. We also piloted a model that segmented the testing and the treatment phase, and that was really an effort to scale by utilizing the community health workers to go out, and they brought the HPV self-sample tests to the doorsteps of these women. They collected their sample at home, and then the women were contacted via SMS message to return for their treatment in their community at a later date. So while that took some of the time pressure off of the women for waiting, we did notice a larger loss to follow-up because, you know, they're not sitting right there like Dr. Gordon is saying, and it didn't give us the same numbers that we got from our single visit model. So we're still learning in this project as we're going, but I think retention is really important. At the end of the day for us, I think that we're pleased to see the scale up in screening coverage that it's creating, but that's one of the issues that we're working to combat within our different models of this.
One super quick follow-up. Have you considered home delivery of the, or kind of like home management or anything like that on the kind of the treatment end?
We haven't gone that far. I've thought about it for women that are positive and aren't coming to our set up tent area to get the treatment. I've thought of that, but that's not something that is readily, yeah.
Thank you so much.
Oh, thank you for the questions.
Hello, thank you very much for the work that you do. I really appreciate you for the sacrifice that you do to have served those communities. One of the questions that I have, I'm originally from Nigeria, and I've been here for a while, so I'm getting more knowledge. I'm into now in medical healthcare facility, so my knowledge is building. One thing that I want to know is, do you get like the support and the help you need from the local government officials while you are serving their community?
Yes and no. We would certainly like more support, but it depends where we are. But if we're just talking about our mobile clinic, we are embraced. The local government has supported us by providing the community health workers and their transportation fees back and forth to our education seminars. But you know, these local governments don't have any money. And to ask them for a real input into it, we do, but we're not going to get it. The funds and the monies come from other resources.
One more question regarding the government officials. Do they, knowledge is power in the sense that for now I have gained a lot of knowledge concerning health and community health. But in our locally, do you guys have the opportunity to educate those people, officials, of the importance of being screening women, kids, and those preventable diseases?
Yeah, definitely. And Kisumu County, where we've launched this project, has a really robust Ministry of Health. There are a lot of really robust programs within the ministry, and I think they even actually have a national cervical cancer control program in Kenya that was launched about 4 years ago. So I think that on a lot of levels, at least where we've piloted this project, the education is there and the knowledge is there. And it's like Dr. Gordon said, really the resources that are lacking to implement a lot of these projects. Like Dr. Gordon said, there's really positive reception to these kinds of projects because a lot of officials in the Ministry of Health want to see these kinds of things implemented in their community for their people, but they just don't necessarily have the resources to carry it out.
Thank you.
Well, it looks like we're out of time. So thank you. It was a pleasure for me to be able to share what we've been doing with all of you. Thank you.